Welcome to the deep dive. Today, we're plunging into a really serious topic for horses and, well, anyone who cares for them, equine aspiration pneumonia.
Yeah, it's definitely a heavy hitter.
So just to lay it out simply, it's basically when stuff, food, water, sometimes even medications, accidentally gets into the horse's lungs. It goes down the wrong tube, essentially, not the esophagus where it should.
Exactly. And we really need to stress this isn't just a little cough. It's serious. That foreign material triggers inflammation, infection. It seriously messes with the horse's ability to breathe. It can absolutely be life-threatening, no question.
Right. So in this deep dive, we want to unpack how this happens. In some ways might surprise you, and how vets figure it out. We'll look at what treatment involves, which is usually pretty intense, and crucially, prevention. How can you stop it?
Sounds like a plan. There's a lot to cover there.
Okay, let's start right at the beginning. How does this foreign material actually end up in the lungs? What are the main ways?
Well, the number one cause, far and away, is esophageal obstruction. You probably know it as choke.
Right, choke. That's when they can't swallow properly.
Precisely. Food gets blocked in the esophagus. So saliva and feed material back up, and then they can sort of spill over, reflux into the back of the throat, the nasopharynx. And from there, it's a straight shot down into the trachea and lungs. Aspiration.
Ah, okay.
And the longer that choke goes on, the higher the risk. It's a direct link.
So choke is a huge red flag.
Yeah.
What makes a horse prone to choking? I know eating too fast is one thing.
Oh, absolutely. Bolting feed, we call it,
Yeah.
big factor. Also, not chewing properly, that often points to dental issues needing attention. Then there's not enough water, especially with drier feeds like beet pulp if it isn't soaked right. Sometimes they swallow weird objects. Or, and this is important, eating while they're still groggy from sedation or just coming out of general anesthesia. Their reflexes are down.
Got it.
And sometimes there are underlying problems with the esophagus itself, like megaesophagus or strictures, that make chirking more likely.
Okay, that makes sense.
Yeah.
Now, you mentioned something surprising earlier about vets potentially causing it.
Yeah, that's the iatrogenic category. It means it's related to medical treatment or procedures. It's less common, but it happens. Usually involves giving oral medications or fluids incorrectly.
Wow. So even giving routine meds can go wrong. How does that happen?
It can. Say, if liquid medicine is syringed in too fast, too forcefully, the horse can't cope and aspirates some. But the really critical one, the most dangerous iatrogenic cause, is incorrect placement of a nasogastric tube, putting it into the trachea, the windpipe, instead of the esophagus.
Oh, wow. That sounds bad.
It is. That's exactly why a vet must do nasogastric tubing. They have checks, like feeling for negative pressure, maybe starting with water, to be absolutely sure it's in the right place before giving meds or fluids.
Okay, that's a crucial point. Expertise matters.
Absolutely. Then there are neurological issues. Problems affecting specific cranial nerves 9 and 10, or muscle diseases affecting the throat. These can cause dysphagia, which is just difficulty swallowing. Makes it hard for the horse to protect its own airway.
So the signals or the muscles for swallowing aren't working right?
Exactly. The whole mechanism is compromised.
Can you give some examples of those kinds of conditions?
Sure. Things like botulism, you might have heard of Shaker-Foal syndrome or forage poisoning. Viral encephalitis like EVE. Also polyneuritis equi, lead poisoning, selenium deficiency causing white muscle disease, even HYPP, hyperkalemic periodic paralysis.
Quite a list. Shows how interconnected everything is.
It really does. And there are a few other risk factors worth mentioning briefly.
Right, like things that just generally weaken the horse or
Yeah.
suppress reflexes.
Yes. General anesthesia itself, as we touched on. Airway reflexes are just dampened. Vulnerable time. Also birth defects like a cleft palate in foals. Milk or food can go straight into the nasal passages and down the trachea.
Oh, poor things.
Yeah, and then things like severe GI reflux, maybe from a blockage further down, or even just extreme weakness or respiratory distress can make it hard for them to keep their airway clear. And for newborn foals, meconium aspiration during a difficult birth is another pathway.
Okay, so we've covered the how. Now, for someone watching their horse, what are the signs? What should you look for if you suspect this might be happening?
Well, the history is super important. Did the horse just choke? Was a tube passed recently? Any meds given orally? Recent sedation? Any signs of neurological problems?
So context is key.
Absolutely. And then look for things like difficulty swallowing the dysphagia we mentioned, or maybe drooling excessively, ditylism, or seeing actual food, water, or milk coming out of the nostrils. That's a pretty clear sign something's wrong with swallowing.
Okay. And if a vet comes out, what clinical signs will they look for during the exam?
Typically, you'll see a fever. The horse will likely be depressed off its feed anorexia. A cough is common, often sounds kind of wet or productive. And they'll be breathing faster, tachypnea, maybe with more effort, dyspnea, labored breathing.
And you mentioned something earlier about foul-smelling breath.
Yes, that's a big one. Foul breath or foul-smelling nasal discharge really strongly suggests anaerobic bacteria are involved, which is very common with aspirated material. And listening to the lungs, auscultation, you'll often hear abnormal sounds like crackles or wheezes.
In really bad cases.
In severe situations, you might see cyanosis, that bluish tinge to the gums indicating low oxygen. And chronic cases, maybe just a persistent cough, weight loss, can't exercise like they used to.
So lots of signs, but how do vets actually confirm it's aspiration pneumonia? What are the definitive tests?
Imaging is usually the first big step. Chest x-rays, thoracic radiographs. We typically look for cloudiness, opacity, often in the lower front parts of the lungs, that cranioventral distribution, yeah, because gravity pulls the aspirated stuff down there.
Makes sense.
But it's worth noting those changes might not show up on x-ray for a few days after the aspiration actually happened.
Ah, okay, so it takes time to develop sometimes.
Exactly. Contrast x-rays can sometimes help if we suspect an underlying esophagus problem. And ultrasound, thoracic ultrasound, is great too. It's really good for seeing fluid in the chest cavity, pleural effusion, or thickening of the lining, even abscesses near the surface. Plus, it helps guide drainage if we need to put a needle in.
Okay, imaging gives a strong clue. What about nailing down the infection itself?
That's where airway sampling comes in. A transtracheal wash, TTW, or a bronchoalveolar lavage, BAL. Those are the definitive diagnostic tools.
And what do those tell you?
Well, the fluid collected is analyzed. Cytology, looking at the cells, will usually show lots of neutrophils inflammation, and sometimes you can actually see foreign stuff like feed particles under the microscope. And critically, we do a bacterial culture and sensitivity. Identify the exact bacteria, including those anaerobes, and figure out which antibiotics will actually kill them. That targeted therapy is vital.
Makes sense. Any other tests that help?
Yeah, blood work. A CBC can show a high white blood cell count, especially neutrophils, and high fibrinogen, which indicates inflammation. Specific blood tests might help find an underlying cause, like testing for lead or checking selenium levels for white muscle disease.
Right.
And endoscopy using a camera scope can be useful too. Look down the airways or the upper GI tract to spot problems like paralysis or maybe a mass, or just to double-check nasogastric tube placement after the fact.
Okay, this definitely sounds complex and pretty serious. Once you have that diagnosis, what's the treatment plan? It sounds like it needs to be aggressive.
Oh, absolutely. Treatment is usually long, it's aggressive, and often means the horse needs to be hospitalized. Getting started early makes a huge difference in the outcome.
So let's talk meds. What kind of antibiotics are we looking at? I imagine it's not just one simple pill.
Definitely not. You need broad-spectrum antimicrobials right away. They have to cover everything, gram-positives, gram-negatives, and, crucially, those anaerobic bacteria that often come up with aspirated gut contents.
Okay, so what are some common drug combinations vets might use initially?
A very common starting point is penicillin, or maybe ampicillin, combined with an aminoglycoside like gentamicin or amikacin. And often, metronidazole is added specifically to target those anaerobes. They can be really tough.
Are there other options?
Sure. Depending on the situation, drugs like cefdufur, trimethoprim sulfa, or chloramphenicol might be used, but the key is adjusting the plan based on those culture and sensitivity results we talked about.
Right, tailoring the treatment.
Exactly. And it's usually long-term treatment. We're talking weeks, maybe 2 to 4 weeks, sometimes even longer, monitoring how the horse responds.
Wow, okay, antibiotics are key. What about just general support and making the horse comfortable? That must be important too.
Hugely important. Supportive care is critical. We use NSAIDs, non-steroidal anti-inflammatories, like flunixin or bute, to control fever, inflammation, and pain. FAVI fluids are essential to keep them hydrated, especially if they're not eating or drinking well. Nutritional support is vital too. Sometimes that means feeding a liquid diet through a nasogastric tube if they're really off feed.
And if they're struggling to breathe.
Oxygen therapy, definitely. Usually through a nasal cannula, giving oxygen at about 6 to 10 liters per minute if their blood oxygen is low. Nebulization can also help sometimes, delivering saline or medication as a mist to help break up and clear secretions from the airways.
You mentioned fluid in the chest. Pleural effusion can happen. How is that managed?
If there's significant fluid buildup, it needs to be drained. That's done either through thoracentesis, using a needle, or sometimes by surgically placing chest tubes for continuous or repeated drainage. Sometimes a one-way valve is used with the tubes to let fluid out but prevent air from getting in and collapsing the lung.
So it's a multi-pronged attack: antibiotics, anti-inflammatories, fluids, oxygen drainage.
Pretty much everything we can throw at it.
But just treating the pneumonia isn't the whole story, right? You mentioned preventing it from happening again.
Absolutely essential. You have to identify and manage the primary underlying cause. Otherwise, you treat this bout and it just happens again later.
So fixing the root problem.
Exactly. That might mean treating choke promptly and effectively, sorting out dental problems, managing the neurological condition if possible, being meticulous about tubing technique, or for foals with something like a cleft palate, maybe surgical correction if that's an option. It's about stopping the cycle.
Okay, so looking at the bigger picture, what's the usual outcome? What's the prognosis, and are there long-term effects even if they recover?
Honestly, the prognosis is often guarded to poor, especially if it gets complicated, developing into pleuritic pneumonia, which is infection spreading to the chest lining, or if lung abscesses form.
So it can be fatal quite often.
Unfortunately, yes. Mortality rates can be high, and even horses that survive with aggressive treatment might end up with permanent lung damage. That could mean chronic respiratory problems, maybe limiting their athletic future, or just their overall quality of life. It's a tough battle.
What are some of those serious complications besides the lung damage itself?
Well, beyond the pleuritis and abscesses, you can see septicemia infections spreading through the whole bloodstream. Thrombophlebitis, which is inflammation of veins, often where Farvai catheters were, disseminated intravascular coagulation, DIC, a really nasty clotting disorder, and even laminitis can be triggered by the systemic inflammation and endotoxins released from a severe infection.
Wow, laminitis too. That just shows how systemically serious this can get.
It absolutely does.
So, given all this,
Mm.
the difficulty, the poor prognosis, prevention seems paramount.
It really is the best strategy. Fundamentally, it boils down to preventing or avoiding those primary causes we talked about at the start.
Right. Careful feeding, good dental care, caution with sedation, proper medication techniques.
All of that. And here's a really critical preventative insight. If you suspect aspiration might have occurred, say, right after a horse chokes, even if it seems resolved, starting broad-spectrum antibiotics proactively before you even see signs of pneumonia, that is highly recommended. It can really improve the outcome by tackling potential infection before it gets established.
That's a great practical tip. Hit it hard and early, even preventatively.
Exactly. And then monitoring closely, maybe with follow-up x-rays or ultrasound, helps track progress and catch any developing problems quickly.
Wow. This has been, well, a really deep dive. It certainly highlights just how complex and challenging equine aspiration pneumonia is for the horse, for the owner, for the vet.
It truly is. It underscores that you need quick, accurate diagnosis and then really aggressive, sustained treatment to have the best shot at a good outcome.
So thinking about this for you listening, what's the big takeaway here?
I think this whole discussion really drives home how vital vigilance and prompt, informed action are in any critical health situation, maybe not just with horses. It's a stark reminder, isn't it, that sometimes the most dangerous threats are the silent ones happening deep inside, and you need that deeper understanding to fight them effectively.